Well, good afternoon to folks who are joining. Welcome to January 2022 Arizona Community Grand Rounds. We will get started with some introductions in just a second. We'll let people connect in who have been sitting in the waiting room and those who are coming from other meetings and other activities. If you're new to these rounds, we hold these rounds once a month. They are co-hosted by the NARBA Institute and my colleague, friend, and mentor, Mary Jo Gregory, President and CEO of the NARBA Institute. Thanks, Mary Jo. And co-hosted by Health Choice Arizona, which is an operational business line of Blue Cross Blue Shield of Arizona that focuses on Medicaid members and dual Medicaid Medicare members. We hold rounds on a monthly basis. Rounds are recorded and available at the conclusion of each session, and you can see the rounds that go back into the year 2020 when we began them. If you're interested in seeing recorded sessions from the past, we'll put a link into the chat for folks. You're welcome to do that. There's no need to register. CME or CEUs are not available for reviewing previous rounds, and they're not available for today, although we do have those available for some sessions. We're pleased in these rounds to have the opportunity to highlight both existing as well as emerging best practice solutions to challenging situations, whether they be related to the pandemic or just related directly to healthcare delivery and innovation, which is what today's session is for. And we're so pleased to have a real wealth of presenters who have shared expertise with us over the months and will be sharing expertise with us today. If you have ideas about presenters and topics that you'd like to hear about, please don't be hesitant about sharing them with me or anyone else at Blue Cross Blue Shield of Arizona. And I'll put my email in the link just so you have that if you'd like to share that information.
Recording in progress.
For our panelists, if we could just make sure folks are on mute. And for those who are joining as participants, you have come in on mute, and you've come in actually as a participant. So you won't be able to go live with your microphone, but you will be able to ask questions in the Q&A and chat. And I invite you to do that at any time during the session, and I'll do my best to keep track of those and to ask our presenters those questions as we go along. So we're going to jump right in then with this month's session. In doing that, I'd like to introduce two key leaders and colleagues and friends of mine at the Children's Hospital of Philadelphia. Dr. Lou Bell, who's the division chief of pediatrics, general pediatrics at the Children's Hospital of Philadelphia, colleague, friend of many years of mine. So Lou, thank you for joining, and thank you for your facilitation of this important work. And Dr. John Chuo, and John is another colleague that I've worked with for a number of years. John's the co-director of the Digital Health Innovation Core at the Research Institute at the Children's Hospital of Philadelphia. He's also a neonatologist. And may I say, just a really, really cool, interesting, and good guy. So Lou, thank you for your work facilitating this project over the years that have brought it to this point, along with the leadership from Mary Jo Gregory. And John, I'm going to turn it over to you to do a brief introduction.
Great. Thank you so much, Mark, and really appreciate the opportunity and this invitation to present our work. I just want to say that the whole thing, just from a historical standpoint, this whole effort had started about 5 years ago when we were trying to tackle two big problems. I've got some slides, but that's okay. I can just talk through them.
No, that's okay. Hey, Jen, could you bring up John's slides there again? There you go.
Oh,
thanks.
Yeah, thank
and by the way, I want to give a shout out to Jennifer Pierce, who I ask and she makes things happen. So thanks, Jen.
We all have brilliant people who can do that and help us along that way, Mark. So thank you, Jen. So the two big problems in healthcare delivery for all pediatrics, for that matter, especially at this environment that we live in now, but for Indian health pediatrics about 4 or 5 years ago, was that there was a shortage of subspecialists, coupled with when there are subspecialists, children cannot access them readily. And so the Indian Health Service, as facilitated by Mark actually, and was introduced to us, and between with Lou Bell's efforts with the IHS, we were able to begin to brainstorm on how to tackle and solve these two big problems. And we wanted to do this in the context of a very sort of, doable and well scoped out project. And Teleautism, fell into our laps, and that's why we're starting it. So click, please. So the question here is, how can children with autism in the Indian Health Service get service sooner in order to improve their developmental outcomes? And that was really sort of the, quintessential question that we were asking ourselves. Click, please. So what we came up with from a memorandum of understanding that was worked out between the Department of Pediatrics at CHOP under the sponsorship of Lou and the Indian Health Service was a collaborative telecare model. And this model was something that Mark had a big part to do with, as well as we try to really think through what this model ought to have. I was the lucky person in the right place at the right time to help execute and kind of put this model together. So I was really appreciative of it. But if you do a few clicks, Jen, I just want to show you the tiers and the ideas of this model. That's great, thanks. So it's based upon 5 tenets, principles, if you will. It ought to have value care. We ought to be able to measure the value of telecare, higher quality and lower cost. It ought to be able to facilitate the definition of what best practice looks like. These virtual hubs of care, which, as you'll see, will convene expert clinicians, and by its nature, will be able to allow best practice guidances to kind of be put forth. We want to absolutely improve access, so more providers accessible to patients via using technology, teleconsultation and teleclinics. And then because of this staffing burden, that's sort of the elephant in the room, we want to do this model in a way that can actually share the staffing burden across the institution. So multiple institutions collaborating together, as opposed to being competitive with each other, but collaborating with each other in order to access, make care available. And then underneath all this is a reliable broadband and platform connecting patients and providers. And you see that there's a lot of effort, especially by the FCC recently, to really kind of bring broadband and platforms out there to the underserved population. So with that as a background in this collaborative telecare model, the autism work that you're going to hear in a little while by Amanda and Margaret is really sort of the pilot of testing this with one institution for one population in one city, and with one subspecialty. What we want to do is begin to expand this with multiple institutions, multiple subspecialties, and multiple sites. But we want to start here first. So next slide, please. So what I'd like to do, it's great pleasure to introduce friends and colleagues, Dr. Amanda Bennett and Dr. Margaret Ray. And you're going to see that the collaborative nature of this is just so palpable. Amanda completed her developmental and behavior pediatrics fellowship training at CHOP here and got a master's in public health at the University of Pennsylvania during her fellowship. She currently is a national well-renowned expert in autism. She clinically chairs CHOP's Autism Integrated Care Governance Committee. She directs the Autism Care Center in Philadelphia, and she's the medical director at the CHOP Center for Autism. And her research in clinical includes autism spectrum disorders and Fragile X syndrome, and particularly interested in development and the implementation of clinical and teaching programs that is around ASD and related developmental behavior disorder. So Amanda has been terrific as our developmental pediatrician in really kind of forwarding this, but we alone couldn't do this. And Margaret Ray is her co-lead at Tuba City, and she's also from the Northeast. Completed her training at Columbia at New York Presbyterians, and then immediately after that, she moved to New York City, from New York City to Tuba City, where she's been practicing as a general pediatrician at the Tuba City Regional Healthcare Corporation. Her interest is in the care of underserved populations, development, behavior pediatrics, obesity, and adolescent mental health. And so without much more ado, I would love to introduce you to these two great individuals, and they were going to tell you a little bit about what the program is and what they've been able to accomplish in this amazing, actually short time. So thank you, Margaret, and thank you, Amanda, for presenting.
Thank you, John. So Jen, if you're able, or actually no, Meg, you're pulling up our slides. Correct?
I will pull up the slides now.
And Meg, while you're doing that, just a note of thanks again to you and to Amanda for this really incredible cross-country collaboration. We will have time to talk more about that. And hopefully, Dr. Bell, have your thoughts on this too at the conclusion of your remarks, Drs. Bennett and Ray. So Amanda, take it away. Thank you.
Thank you. So we're going to start off, Meg, if you want to advance to the next slide. Just anytime I give a talk, we include disclosures. Meg does not have any disclosures to share today. I do have some research funding that I always just share. None of it is relevant to this work, but I just like to put it out there. And also my husband does work for a pharmaceutical company, but has nothing to do with autism. So that's just there for folks to know. Next slide does have a couple of objectives. So really our goal for today is to explore how subspecialists in today's instance, developmental pediatricians, can partner with primary care providers within the medical home setting, and talk about how primary care subspecialty collaboration through telehealth can decrease time to diagnosis and increase access to services. Next slide. So this is an outline of what we're going to cover today, and Meg is actually going to kick us off talking a little bit about the background.
Yeah, so sort of to walk through the outline, but I wanted to start with an introduction to Navajo Nation and Tuba City more specifically. And then we'll talk about autism prevalence and unique challenges on the Navajo Nation. Then Dr. Bennett's going to present information on our teleclinic collaboration. And we'll conclude with some information on current resources and services for our patients and future directions for autism diagnosis and treatment for kids on Navajo. So the first thing that's important to understand about the Navajo Nation is that it's quite big. So it's primarily located in northeastern Arizona, but extends into New Mexico and southern Utah with a landmass of 27,000 square miles. So to give you a sense of scale, that's bigger than 10 states in the US and about halfway between the size of West Virginia and South Carolina. The second thing that's important to know about the Navajo Nation is that the population density is very low. So the population of the entire Navajo Nation is 170,000 people, which is roughly 1/3 the population of Tucson. And it's hard to grasp in some ways just how rural this area is, but it really significantly impacts clinical care because many of our patients have to travel long distances for their appointments, frequently on unmaintained dirt roads. And it's also worth mentioning that poverty and a lack of access to basic services are major issues on Navajo. So roughly 1 in 3 households doesn't have access to electricity or running water. There's also an absence of jobs on the Navajo Reservation. The unemployment rate is about 45%, and approximately 40% of families live below the federal poverty line. So when you think about the scale of unemployment, the scale of poverty, and the absence of basic services that most of us take for granted, you start to get a sense of the structural determinants of behavioral and developmental health for kids on the reservation. So you may notice that there's a donut hole in the Navajo Nation map. This is the Hopi Reservation. So Tuba City is on the border of the Navajo and Hopi reservations, and we end up treating both Navajo and Hopi patients. And these are very distinct cultures with different languages, different religions, different social customs. But the Hopi Reservation, like Navajo, is big and sparsely populated. So it's a little over 2,500 square miles, about the size of the state of Delaware. And in that entire area, there's only a population of about 9,000 people. And the Hopi Reservation does have its own healthcare center, but there are no pediatricians there. So care is provided exclusively by family medicine providers. So for a lot of Hopi children, particularly those with more complex medical or developmental issues, they travel to Tuba City for their care. Then I wanted to just mention sort of a background on the healthcare system on the Navajo Nation. So the reservation is divided into these 8 catchment areas, and each one of these is served by a community hospital that provides outpatient primary care, as well as typically some degree of inpatient services. And when this system was conceived in the 1950s, all these hospitals were run by the Indian Health Service, which is part of the executive branch of the federal government. It was initially under the Department of the Interior, but now falls under the Department of Health and Human Services. And that continued to be the case through the end of the 20th century. But in 2000, a new law was passed that provided a mechanism for transferring administration of hospitals and schools from the federal government and the Indian Health Services to local tribal communities. And these tribal hospitals are referred to as 638 facilities, named for Public Law 93-638, the Indian Self-Determination and Education Assistance Act of 1975. And the hospital in Tuba City went 638 in 2002. So it's no longer a federal program. And instead, the organizational structure is similar to any other rural community hospital with a board of directors and a CEO. The big difference here being that the entire board and virtually everyone in senior leadership is Native, and many grew up in this community. And so how about Tuba City specifically? So we are located here on the Western Navajo Reservation, about halfway between Flagstaff to the south and Page to the north. And Tuba is the largest town on Navajo with a population of just over 9,000 people. And our catchment area is 34,500 patients. And the population is young. Almost 30% is under the age of 18, according to the most recent census data. So we're serving a community of almost 10,000 children as pediatricians. So I think that gives you a sense of the area and the population that we serve here. And now we'll switch gears a little and talk about autism and its prevalence, both nationally and locally. And I'll turn it over to Dr. Bennett to talk specifically about autism.
Great. So at the risk of telling you information you may already know, I thought it was important to at least define what we mean when we're talking about autism spectrum disorder. And the most recent criteria for determining that a person meets criteria for autism is that this is a person that has deficits in their social communication and interactions. And this person has restricted, repetitive, or sensory focused patterns of behavior and interests. These symptoms tend to appear in childhood and need to have some degree of impairment in order to be calling this a disorder. And we want to make sure that we are not saying someone has autism if they also have an intellectual disability or global delay that is explaining why they are presenting with deficits in their social communication. So autism is separate from your cognitive or developmental abilities. It is really referring very specifically to social communication difficulties and behavioral patterns. So I'll let Dr. Ray talk about our prevalence data that we have so far.
Okay. So I just wanted to start with sort of a national idea of prevalence, but the CDC estimates currently that 1 in 44 children in America has autism spectrum disorder. But that number varies a lot by geographic location, racial and ethnic group, and socioeconomic status. So in the state of Arizona, the prevalence is 1 in 40 children. So actually a little higher than the national average. But white children are 1.3 times more likely to be identified than Hispanic or Black children with autism spectrum disorder. And the CDC doesn't even give an estimate for the prevalence of autism in Native American populations in the state. And that's because all of the data that is collected to come up with these prevalence rates is collected in Maricopa County, which is the most populous county in Arizona, but less than 2% of the population there identifies as Native American. And there's really been little research on autism prevalence in Indigenous communities. So there was a 2009 University of Minnesota study that reported American Indian and Alaska Native children with autism were 13% less likely to be identified than white children with a disability. And a study out of Canada found that Indigenous populations were underrepresented in publications regarding autism, and that the true prevalence among Indigenous children was not known and likely underdetected. So from that information, we can kind of conclude it's likely that autism spectrum disorder is equally prevalent in Native communities, but tribal children just aren't being diagnosed. And there's probably a combination of reasons for that, which we'll get into a little bit more in the next couple of slides. But to illustrate this point in our own small Tuba City clinic, prior to starting our teledevelopment clinic in 2019, a quick EMR search for autism spectrum disorder yielded 30 patients under age 18 with that diagnosis. So for an estimated population of about 10,000 children, that gives us a prevalence of 1 in 350. Since we started our collaboration with CHOP and Dr. Bennett, we have more than doubled the number of children identified in the last 2.5 years. And so our prevalence rate now is more like 1 in 100 as a very rough estimate. So now we'll talk about some of the challenges that are unique to autism diagnosis and treatment on Navajo Nation. And the first challenge actually comes from statewide regulations. So I've written out here the Arizona Administrative Code, R6-6-302. So Arizona state law requires diagnosis by one of these listed professionals highlighted on this slide: a child psychiatrist, psychologist, neurologist, or developmental pediatrician, in order to qualify for autism services covered by Arizona Medicaid or Access and to receive appropriate school resources and funding. So your average general pediatrician, like me, cannot make an official diagnosis of autism to get kids started with these services. Children need a comprehensive evaluation by one of these specialists in order to qualify. And we know from years of autism research that outcomes are better the earlier you intervene, so time is really of the essence here. And getting an expedient appointment with a developmental pediatrician in this state is quite difficult for most patients, and especially for our patient population living so far from urban centers like Flagstaff or Phoenix, where these evaluations are typically available. Most developmental pediatricians in this state are scheduling out 6 months or more in advance, and getting to Phoenix for an appointment can be a real challenge for our resource-poor patients in the more rural areas, requiring a drive of up to 5 to 6 hours in each direction. I think it's also important to understand some of the Western versus Navajo cultural differences, which contribute to the challenge of identification and treatment of kids with autism. So Western medicine identifies autism as a disease or disorder, which needs to be fixed. Therapy and services are aimed at helping children assimilate, so teaching kids how to navigate social interactions, how to communicate and function in a way that doesn't come naturally to them. Eliminating problem behaviors like tantrums, repetitive behaviors, rigidity is a major goal, and reinforcing social norms like eye contact, conversation, interest in others aims to help kids navigate a social world. On the other hand, traditional Navajo teachings view neural differences as beautiful, with the goal of appreciating these differences and living in harmony. The Navajo philosophy of Hosho is comprised of principles that guide one's thoughts, actions, behaviors, and speech, and describes a way of living in beauty and balance. Hosho recognizes that differences between individuals help to make up the balance of the community and the world, and there's less of a focus on fixing or progress as there is in Western ideology. In fact, the Navajo lacked a word for disability prior to the introduction of this Western concept. And the importance of family and culture means that Navajos care for their elderly and disabled within their own cultural community. So now I'm going to turn the presentation over to Dr. Bennett to talk about our teleclinic collaboration, having kind of set the stage for why this clinic was so important.
Thank you. So John alluded to this. This clinic really began as an alignment of two missions. So the mission of the Indian Health Service is listed here, and it's a partnership really with American Indian and Alaska Native people to raise their physical, mental, social, and spiritual health to the highest level. And CHOP has had a mission to be the world leader in the advancement of healthcare for children by integrating patient care, excellence, innovative research, and quality professional education. So the alignment of these two missions, you can go to the next slide, led to this collaboration. And planning actually began in 2016. I'm shocked when I think how many years we've been talking about this. And as John mentioned, the goal was really to pilot one subspecialty service with one primary care practice in the hopes that if we are successful in developing a model that could then be expanded to multiple subspecialties in multiple settings. That's where that memorandum of understanding was initiated. And that's where we created the idea of this collaborative telecare model. Our first clinic was held in May of 2019, and that was thanks to generous funding from the NARBA Institute, which provided a pilot grant for us to initiate the clinic and gather some data on how well we were achieving this goal. Next slide. So I think it is important to highlight, Meg and I did not just stumble into these roles. I think we were selected for specific reasons. Meg's been a pediatrician since 2013, and she came to this collaborative model with some experience with autism. So she was trained on the STAT, which is a brief play-based behavioral observation tool that can be used in the primary care setting to screen for autism symptoms. And she had participated in an Echo Autism telecollaboration, teleconsultation program, which allows community providers to connect with autism specialists and present cases and learn more about how to support their patients in the primary care setting. I have been a developmental pediatrician since 2008, and my clinical and research focus has primarily been on autism and Fragile X. And through some of my work within the national network that John mentioned that I'm a part of, I was lucky enough to be able to lead an Echo Autism clinic out of CHOP, out of Philadelphia. And that was really one of the first telehealth experiences that we had in the autism program at CHOP, was this teleconsultation model with primary care providers. And I think that is partly how I got nominated to pilot this clinic with Meg. Next slide. So to give you an idea of what the clinic model looks like, prior to any clinic visit, families are asked to complete an intake questionnaire. I believe a lot of times this actually happens with the primary care provider over the phone or at an in-person visit, so that we can get a little bit of information about the child's history and some of the concerns. And that information is then emailed to us at CHOP. The clinic itself consists of 3 visits that are 60 minutes apiece. And so prior to that clinic visit, I have 3 intakes that I'm able to review and have a sense of the child that I'm going to be seeing and what potential concerns people have had. On the day of the clinic, I am meeting with the family. They are in a room with Dr. Ray and the child is there. There are toys out. There's a small table that the child can sit at and play with those toys. Dr. Ray sometimes plays with them while I'm interviewing the caregiver. And the camera in the room is set up in a way that I'm able to see the caregiver, Dr. Ray, and the child, and most of the room. However, sometimes these children are young and moving around. And so having Dr. Ray present in the room to be able to share observations, if the child has their back to me, if I can't quite hear what the child has said, or if they're in another part of the room that the camera doesn't quite reach, that's been very valuable. If I'm able to reach a diagnostic conclusion at the end of the visit, I am providing that information to the family at that same appointment and giving them some feedback about next steps and additional resources that they might find helpful. And then after the clinic visit is over, I then email my diagnostic report back to Dr. Ray, who can share that with the family as well as her colleagues, her primary care colleagues that may have referred the patient. And she can help assist in making other appropriate referrals to additional therapy programs or community resources. Next slide. So I think it is important to highlight that there are lots of ways that autism diagnosis happens depending on what type of clinic or program you're in. And many of the academic subspecialty medical centers that have developmental pediatricians will have a much more comprehensive evaluation than I'm able to do over telehealth. This diagnosis is made using the DSM-5 criteria checklist, which is the way that you confirm an autism diagnosis. And it's made with a fairly comprehensive history that I'm taking. So I'm asking the caregiver lots of questions about communication behaviors, Sometimes I'm witnessing some things that I can bring into the questions to highlight some specific concerns. I ask about the child's social interactions, both within the family and ideally if there are opportunities to observe them with other children outside the home. I ask about their play preferences and the types of things they like to do for fun. And then I ask about their general development, just to get a sense of their mental age so that I have an idea of what they should be doing developmentally in terms of social communication skills. I do also try to screen for other behavioral symptoms that might need to be monitored. We know that ADHD and anxiety are much more common in people with autism, so we try to make sure that we're capturing a sense of those symptoms as well. And I screen for common medical symptoms that we know present more often in the autism population. So sleep, feeding, toileting issues. At the end of that comprehensive history, I am completing a DSM checklist. And if I am able to confidently make the diagnosis based on that checklist, then I'll talk with the family about that finding. There are cases where I'm not confident at the end of a first visit with a child. And in those situations, it's been really nice that Dr. Ray and I have been able to offer follow-up video appointments with the family. In some cases, it's allowed the child to participate in a childcare setting or a preschool setting for a period of time so that we can get more data about their interactions with other children. In some cases, I've used additional rating scales that Dr. Ray has given to the family to allow teachers or therapists or other caregivers to provide additional data about the child's social communication behaviors or maybe their ADHD behaviors. Next slide. So to give you a sense of where we are so far. So this data is based on the first 2 years of clinic. So this is from May 2019 to June 2021. 49 children were scheduled for their appointment. 40 were able to make it to the clinic and be evaluated. So about 82% of children referred were seen. 33 of them were given a diagnosis of autism spectrum disorder. Again, they were referred because that was a concern. So that high rate of diagnosis is not surprising. The other 7 were not identified as having autism, but did present with other developmental or behavioral diagnoses. So I feel like there was still benefit in having them come to this visit and being able to help clarify what was going on in terms of their clinical presentation. The average age of the child seen in those first 2 years was 6.3 years, but the range was from 2 years to 17 and a half. Next slide. So the big question is, what did we really change with the creation of this telehealth model? Next slide. And this is busy, but it's really fascinating to look at this data. So prior to this clinic, as Dr. Ray mentioned, patients were waiting an average of 7 to 9 months from the time their pediatrician first raised a concern about possible autism to being able to be seen and have diagnostic clarification. In the first 3 to 4 months of our clinic, we were able to get the wait time down to about 52 days, which is less than 2 months. So we had a lot of kids coming in who had been waiting for a long time with that concern, and we were able to kind of get that backlog out of the way fairly quickly within the first few months of clinic. And then we had a few patients who, if you look in the middle from September until early 2020, we had a few patients seen. There were actually 5 patients who came to clinic during that stretch of time who had waited over 3 years to have their diagnostic evaluation. So these were patients where they were a little bit older, there had been concerns at a very young age, and for a variety of reasons, they didn't get into the clinic right away. It took a little more time, and those patients kind of skewed our wait times up to a higher rate. However, from February 2020 to the present day, we have been able to get that wait time back down. We're down under 6 months and continuing to decrease the wait time from initial concern to diagnostic clarity every month that we are seeing patients. And that includes the first few months of the COVID pandemic, where our clinic really wasn't a focus for the providers in Tuba City at the time. We were all trying to pivot and make sure that we were addressing healthcare needs first. And in spite of not having clinic for a couple of months early in the pandemic, we were still able to continue to reduce the wait times. Next slide. And I think this is the most important part of the message of this whole presentation. You know, Dr. Ray talked about the Western view of autism as being a disorder, and yes, we call it a disorder, and we talk about treatment plans. But I think there is also this awareness that recognizing that we can intervene and teach some of these skills means that this person will have less of a disordered appearance. They will have less of a disability if we can help to teach some of these skills that aren't coming as naturally to them. So an earlier diagnosis means access to early intervention and preschool special education, access to some specific behavioral interventions that have been shown to be incredibly helpful in teaching some of these skills and in supporting families to be able to have the best environment for their child. Access to Arizona's Division of Developmental Disabilities resources. And this last bullet to me, I think is the most important, helping families and caregivers and teachers to understand the things that might be a little more challenging for this child, to be able to anticipate ways that we could support these children to have a more successful primary care visit or to have a more successful school day. And having that knowledge comes from the earlier we can recognize these symptoms. Next slide. And then this is really exciting, letting Dr. Ray talk about some of the additional resources we've identified over the past 2 years.
Yeah, so I think that gives a nice summation of sort of where we are with autism diagnosis and how we've been able to reduce wait times, which is a huge deal. But obviously what comes next in terms of treatment and services and resources. So just in terms of the resources and services that we had at the outset of our teleclinic, the autism specific services available to kids on the reservation was pretty limited. So at our hospital, we have 2 speech therapists who work with children, an occupational therapist, and a few physical therapists. So there have been some challenges with staffing and turnover in the OT and PT departments, and it can be difficult to get kids in to be seen consistently for appointments. The speech therapists here have been, I will say, consistent and do excellent work with our kids and managed to actually expand their practice to make accommodations for COVID through a hybrid model, partly in person and partly via telehealth, which was great. Growing in Beauty is the Arizona Early Intervention Program on the reservation and provides in-home services for children up to age 3. And at one point, there was a speech therapist who was a part of Growing in Beauty who was trained in the PLAY project, which is an evidence-based autism-specific intervention for young children. So for a time, she was a great resource, but unfortunately, she left Tuba City about a year ago, and we don't have any additional providers with specific PLAY project training right now. And then the PEEPS program is the preschool early education program, serves children ages 3 to 5 in Tuba City and the surrounding areas, and functions as a special education preschool for the district. And they offer speech, OT, a psychologist, and certified early childhood educators. And a number of our children who've been diagnosed with autism over the past few years have been part of the PEEPS program and have done really well there. The closest applied behavioral analysis, or ABA, which Dr. Bennett mentioned, is the most widely used evidence-based intervention for autism spectrum disorder. But the closest ABA therapists are located in Flagstaff. But as they say, if you build it, they will come. So Tuba doesn't exactly have a grassy field of dreams. But as we've created this clinic and been able to evaluate and diagnose more children with autism, we've been able to increase access to our autism-specific services. So during the pandemic, one of the ABA providers in Flagstaff began offering virtual services, and a number of our patients and families connected with them and began therapy. And we've since referred enough children that there's a big enough cohort of patients in the Tuba City area that the team actually wants to come up to Tuba City and provide in-person ABA services and parent coaching a few times a month. We're currently working on the details of that contract, but as far as I'm aware, that would be the first time ABA services have been available for kids in person with autism on the Navajo Nation. We've also started a monthly meeting with a collaborative team based out of Flagstaff, which includes ABA therapists, speech pathologists, clinical care coordinators, case managers, representatives from the Arizona Department of Developmental Disabilities. And the team is working on developing pathways for getting kids into care and services and tracking and assisting with their progress through the access system. So the goal is to make sure all of our patients and families are aware of and able to get the resources that they're eligible for, including ALTEX, Arizona Long-Term Care System, DDD, the Department of Developmental Disabilities, and insurance coverage for autism-specific therapy. And the teleclinic model has been so successful, we will actually be spreading across Navajo Nation to other sites and starting a new clinic in Chinle this winter. So I wanted to say a few quick thank yous, particularly to Dr. Holdy and Dr. Jager, the former and current chief of pediatrics at Tuba, for their coordination and support of this collaboration and program. It's been really great.
And I've included the CHOP team here as well. So Dr. Bell and Dr. Chuo. Dr. Blum is my division chief who connected me with John and Dr. Bell when Mark initially approached us. And Mark, you should be on here, though you don't fall under CHOP or Tuba City anymore, but you really should be listed under both of these. And then John Devaney, who directs the National Network Relations for Primary Care for CHOP. So really this, Dr. Ray and I do the month-to-month clinic with the families, but it's really a whole team of people that help to create this.
And Amanda, if I just may add to that, forgive the interruption, that there have been so many key folks included in this slide and some others in Arizona, in Tuba City, Dr. Diana Hu, the whole PEDS team there. Hi to you all if you're connected today, as well as the clinical leaders, administrative leaders at State Medicaid Program at Access. Thank you, Dr. Solek. Clinical leadership at DDD in Arizona. Conversations with colleagues at Phoenix Children's Hospital too around the model. Perhaps John can talk about that. So a lot of work and a lot of folks have been part of the forethought, the design that's gone into this work. But Amanda, Meg, you and your teams deserve the credit for, and John's oversight for bringing this to fruition. So forgive the interruption. I don't know if you have additional slides, but I did want to jump in on the special thanks because there may be some folks who are even listening in today, and I think everyone deserves a large note of thanks for the role that they've played in this.
Mark, your timing is perfect because I think the next slide is just thanking everyone for their attention and opening up for questions.
So we have had questions come in, and there are a number of them. There are questions and comments, I think, in a couple of categories, and sometimes people text me too, which, by the way, is fine during the course of these sessions. They're both on the organizational system planning level, and, you know, probably a little bit more conversation, maybe John and Lou, in terms of kind of overall structure, what this looks like in terms of growth and potential partnerships with other children's hospitals like Phoenix Children's in the region, whether this has an opportunity to grow beyond that. And then there are questions in terms of the specifics too, Meg and Amanda. So maybe John, Lou, if you're there and still can come on camera, do you have any thoughts that you'd offer in terms of what we've learned so far from this model? And you explain how Children's Hospital Philadelphia is involved with Tribal 638 governed organization, Tuba City Regional Healthcare Corporation in Arizona. But any thoughts about larger structure and expansion?
Yeah, I can weigh in, and then John can follow up. I don't know. Am I on camera?
You are.
For you guys?
Yeah.
Okay,
good
good.
to see you, Lou.
Good to see you too. Well, I just wanted to, in answer to your question, as John mentioned in his introductory statements, our goal is to move this and scale it to talk with another academic medical center, for example, to join us in this this work, We've currently had some discussions with our own endocrinology group at CHOP, and also with the Hopkins Department of Pediatrics, Johns Hopkins University Department of Pediatrics endocrinology group. Very preliminary discussions. We are in discussions with Chinle, who is not a 638, but it's an Indian Health Service clinic, and so we're in discussions there, which is a little bit of a different agreement, if you will, but expanding both related to autism and some other interests and some other subspecialty. So the goal is to just thoughtfully expand to a different site, another subspecialty. Hopefully we can engage another academic medical center to join us in this partnership. CHOP would still remain as a coordinating center, if you will, but we want to partner nationally if we can to scale this. And so we're making baby steps, and this involves a lot of discussion with how to do contracts with the federal government, how to, I have to say, working with the Navajo Nation and working with Tuba City has been relatively easy. Moving into the Indian Health Service puts another sort of layer of different regulations that we have to sort of, step through. But we're getting there. It just takes persistence. I do want to thank you, Mark, for tweaking CHOP and tweaking me and Joe St. Jim, who's our department chair, those many years ago when we invited you to Grand Rounds, and kind of, you didn't really say it this way, but you said, like, what the heck, CHOP could do this. And so thanks for that tweak. And then just, I really enjoyed today's presentation, particularly Dr. Ray, Meg, your description of the philosophy of the Navajo, and how that intersects with some of the work that you're doing with Amanda. So what a wonderful partnership. Thank you for both of you for sort of showing us the way that this could be done, so that we can scale it in other places. And then finally, I just want to thank John. He's doing the heavy lifting here. I'm supporting him as much as I can, trying to help him connect the dots, but he is really an amazingly passionate about this type of service and telehealth, healthcare in general. So John, thank you for all your hard work. And I don't know, John, if you wanted to jump in and talk a little bit about a little bit more detail about our future sort of scaling this, but I think we're making progress. It's slow, but I think we're making progress.
Yeah, thanks, Lou. Hey, John, before you jump in, Jen Pierce, could you come off from the slide share, or Meg, if you're doing that, so we can come up to there you go. I don't think that everyone could see Dr. Bell before. There are a few John Chuos connected here, and that's because we use the opportunity to bring in a couple of additional friends. So it's not because John's cloned, although he'd like to be cloned. But John, please go ahead. John, you're on mute, sorry.
Thank you, Mark, and thank you, Lou. It really takes a village, and it's a village that at a national scale. So it's not just a local village. I just want to just kind of emphasize the fact of the title of this is collaborative telecare, and it's so important that the principle, the vision of this is not one institution, but many institutions together in an almost a federated way of bringing the necessary care to those in need. And this is even within our borders. This is within the border of the United States of America, where where this need is there. So it's just such a privilege and honor to be able to help make a dent in this. The involvement of the regional and local institutions cannot be overemphasized. I think that is just so important. it was never the intent of CHOP to be in the backyard and just park. It's really our intent to facilitate collaboration. The regional and the local facilities. We've actually had a few conversations a while back with Phoenix Children's, and we would love to just kind of keep talking with other areas in order so that we can, because these patients are always going to rely and need the local and regional healthcare services. As an example of what is happening now at Tuba City and Flagstaff, right? So it's not only the medical need, it's also the support and the holistic needs of the patient. So there's a lot of opportunities. This collaborative care model will involve virtual hubs composed of multiple institutions of a particular subspecialty. Right now, it's autism. There's also opportunity for endocrinology, also opportunity for other things. But the idea is that within these hubs, we're going to have subspecialists that are working together from different institutions. And, it may be that other institutions take the lead in these hubs. And we all work together in such a way. We've already found opportunities and potential opportunities to work together. So we have a teleautism hub, and then there's also remote genetics going on. So autism and genetics, relate in many times, and there's opportunities for these hubs to collaborate. And by the existence of these hubs within subspecialties, we're going to naturally, organically derive best practice of how to practice telecare in this manner and how to integrate telecare with in-person care in a hybrid manner. And so we'll learn from that as well. And so we're really excited about what the potential is. And the most importantly, I think, to be able to bring care, to be able to reduce the wait time of access from 7 to 9 months to 2 months to maybe even lower in the future. It's just really exciting, and it's really kind of really tangible in that aspect. So more to come, but we really would love people to and other institutions to give us call and collaborate and be involved.
Yeah, thank you so much, John. Hey, Jen, would you mind putting, Meg, if you're okay with this, there are some questions coming in the chat that I think you could probably best answer, and people may want to bring directly to you. Maybe some other communities in Northern Arizona interested in services, or maybe how to connect their kids potentially with your program in Tuba City. Jen, if you could put Dr. Ray's email in the chat, then people can connect directly with her. Meg, would that be okay?
Yeah, absolutely. That would be great.
Okay.
Yeah, I'm just noticing that we have 4 minutes and great conversation. We could probably talk for another hour, and there are a lot of very specific questions folks have been asking that I think Dr. Ray and probably Dr. Bennett, linked in through Dr. Ray, can be able to answer. I think you hit some really key points, which is that advancing the timeliness or decreasing access to a specialist and improving timeliness of diagnosis was a key outcome for this. But we knew at the start, you knew, and the collaborators, this wasn't going to address the full needs, the comprehensive needs of service delivery. But that hopefully they would drive, as you've indicated, some of the response to that, improved learning, and maybe some other types of service supports that could be telemedicine enabled, like ABA or otherwise. I think you, Dr. Ray, you very nicely indicated how this has led to some of those future dialogue. But I'd share with folks who are participating from around Arizona that this is just the beginning. There's so much learning to go from this in terms of other types of services related to the care of children with autism spectrum disorder, as well as other types of services for children in general, and unique opportunities we have for partnership and collaboration. Key point, it's 2022. I have to remind myself of that. Happy New Year, everyone. But your slides, Dr. Ben, I think indicated conversation started in 2016. And so it's taken time to get here. Now 2 years of good experience and children receiving services, more timely diagnostic specialty services, as well as related support services. And we shouldn't lose sight of the fact that that children receive very important services as a result of this, as we're talking about system possibilities moving forward. Mary Jo, Gregory, NARB Institute played a key role in providing some foundational funding. Any thoughts that you have at the conclusion of our session today on moving forward, but just a note of thanks to you for your leadership in this.
Well, thank you, Mark, and thank you for everybody that joined and presented. It was just awesome. I think it just goes back to the power of an alliance and the power of sharing a common goal. And as I said earlier, when we were preparing for this, it really speaks to the starfish theory. You know, it helped one kid, and then it built a model and continues to help children in very vulnerable populations. And that is really all about advancing well-being. We are proud, very, very proud to have been with this. I said to John earlier, it was the first thing out of Mark's mouth, really, when we sat down and talked about what kind of things should we do back in 2015. And I'm just very grateful to be part of it and look forward to any of the ideas, both at CHOP as well as at Tuba City and throughout Northern Arizona. We're just very grateful and ready to go to the next level.
Well, thank you, Mary Jo. Appreciate your leadership and the engagement from everyone. Hey, I put my email into the chat, so if we didn't get to your question today, I'm sorry. That's me not keeping track with the questions fast enough and moving through, but please feel free to email me if I can connect you to any of today's presenters. Any folks in Arizona who'd like to learn more, have ideas. There are questions that have been asked about billing that we didn't comment on today. Yes, this is has a business model behind it where the services are billable because CHOP is a registered provider with access in Arizona. But so it's been a combination of learning business model and understanding that. And that's a key part of what's been considered but not presented today. But we will close our first session of Arizona Community Grand Rounds in 2022 with a couple of quick notes. Happy New Year to everyone. Please stay well and healthy as we move into yet another surge in the pandemic. This critical work done by just an amazing group of folks highlighted here. Some of the other names that we mentioned at the close of the work done, even in the course of the pandemic. Another key time to be supporting children, especially vulnerable children in communities in rural parts of our country and in our state. And great opportunities for us to learn moving forward. Our rounds now will be on the first Wednesday of each month at noon. You'll receive announcements on them. Please feel free to share them with anyone else. And on February the 2nd at noon Arizona time, we'll actually have back Drs. Dave Engelthaler, Dr. Bob Arnstein, Dave Engelthaler from TGen, Bob Arnstein from Mayo, and Dr. Rebecca Sonnenschein from Maricopa County to do more of a Q&A on where we are with COVID and the pandemic and that Greek letter Omicron in the state of Arizona. Until then, please stay well. Special thanks for joining today, and thank you to everyone who presented today and has been part of this important program. Take care.
Thank you. Take care.
Thank you.
Thanks, Amanda. And thanks, Meg.
Thanks, John. I think it went really well.
Yeah.
Meg, oh my gosh, so much praise. I know
Oh,
you
you
were
guys
nervous.
were-
You did so great. Those slides were awesome.
Very nervous.
Hi, everyone. This is Liz Junkins from CHOP. I'm the vice president in our care network and work with John and John Devaney. And I just wanted to say what an awesome body of work you guys are doing. Very impressive. So accolades. Well done.
Thank you.
Thank you, Liz. And I just love just watching you guys work together. I had the privilege of attending one of the sessions with Meg and Amanda. It's totally amazing. I wish everybody would work together like this. We'd be taking care of kids very efficiently this way. Thank you.
Yeah.
Oh, by the way, I'm looking at some of the data for the abstract, Amanda. So I should have something for you and Meg soon.
That's great. Thanks, John. I know you've got a busy week. And of course, PAS picks a terrible time to ask for abstracts.
Have a great day.
You
Thanks.
too, Jen.
too.
Thanks.
Bye.
Bye, Meg.
Bye, Amanda.